Thanks very much, Axel, and thanks to ESMO for the kind invitation. I think this is a good way to start this talk. 1.4, that's almost a Kabbalistic number, but that is referred to very often in this type of discussion because this reflects the absolute benefit in median survival in the last three major trials in colorectal cancer, the TML, the aflibercept, as well as the regorafenib trial. I always wondered why we concentrate on this parameter only to refer to these trials. And there are two good reasons for referring to just the median gain that is so small that really would not convince anybody. And the first reason is the need to raise the bar. And the second reason why people kind of disregard all the other parameters when try to lump up all the data from literature and make the issue of raising the bar for approval of anti-neoplastic agents is that the median gain is a very understandable measure of summary measure of the therapeutic effect. So we do need to use an easy language to communicate to both the media, patients, and all stakeholders. Now, there have been two initiatives. One is more advanced, and that's the Blueprint project that has an entire session dedicated to this issue of raising the bar in clinical oncology. And the claim that has been made as far as colorectal cancer is concerned is that meaningful benefit in refractory patients can be regarded as improving survival by 50%. That translates into a, say, miraculistic expectation of 3 to 5 months median gain in median survival, or a target hazard ratio below 0.7, or even a 1 year overall survival shifting between 25% up to 40%. Now, the second initiative, this to me is a bit wishful thinking, more than a realistic approach, for two reasons. Number one, the bar is too high. Number two, it tackles the problem just for the refractory patients and does not put it into a frame. The second initiative, it's just started within ESMO, and there is a task force on clinical value. And the first step that we have taken, kind of a slow approach, is the definition of what is major, substantial, minor, marginal. I'm a bit concerned about this. So what I think we need is a more structured and realistic framework toward the definition of what would be the threshold value to define the clinically meaningful, worthwhile effect. So if you want to have a structured approach, you should not just throw shot in the dark like saying 3 months gain in median survival, or I want a hazard ratio of 0.65 in this condition. You should consider all conditions and see how this, to be realistic, would have impacted on the registration of the agents that now we have on the market, and actually impact so much when they are put all together on the clinical outcome of our patients. So the first issue that should be addressed, again in a structured approach, is to identify the parameters that may define the minimum clinically worthwhile effect. Then, once you have identified the parameters, then you put the threshold, and you do several attempts, and you have 31 pivotal registration trials out of 50 trials on 39,000 patients, and you see what happens if you set the bar at this level, at this level, at this level, because you cannot devastate the system. So that's the approach that we are presently following. So identify the parameter, and I think that this is the best way to start in identifying the parameters. This is the Velour trial, registration trial for aflibercept in second-line colorectal cancer. And as you see, these are the survival curves. The curves diverge at the beginning, meaning that almost every patient benefits. Then you have the very unsatisfactory Kabbalistic 1.4 months gain in overall survival. This would not convince me. And then you have a very non-convincing hazard ratio of 0.81. But then you have to go deeper into the analysis. And the first thing that you should realize is that the two curves diverge and continue to diverge. That's not so bad. So you come to, say, 21 months, and you have a 4 months gain in survival, okay? And if you go further, you even expand more. So you may reason that the absolute increase in survival is 6% at 12 months, but raises up to 10% at 30 months. So 10%, is that convincing? By itself, not so much. But that's a doubling in terms of survival rates as compared to the control arm. I know the numbers are very small, but essentially this brings up the issue, ties up into what we need. That is, what are the parameters to define clinically meaningful levels? And by this analysis, you may agree with me that we may identify, it doesn't show up, but there is a writing in there, oh yes, you can see there, that the hazard ratio and the median gain, that are good ways of expressing summary statistics, reflect small benefit for many patients. Whereas proportional increase and absolute increase at 2-3 years may actually reflect large benefit for very few patients. So here are our two parameters. Why disregarding the small benefit for many? Well, I brought this up within the Blueprint project, and I was completely canned about this proposal. The Blueprint people just want to shoot at large benefit for both few and many. And that is where it becomes unrealistic to me. Well, we can also make the life harder for the drugs to be approved and say, I can shoot at hazard ratio or median gain. I can shoot at absolute increase or proportional increase, or we may shoot to both. And that would not be such a bad idea, because then you match something that is very understandable by patient. And that's the second requirement that we have on top of raising the bar, making ourselves understood, say, put this type of language, of statistical language, into the context of a patient-doctor relationship. And I think this is very important. Now, recognizing these four factors, hazard ratio, median, absolute, and proportional increase, then we have to recognize the factors affecting these when setting thresholds, okay? And for example, the issue of prognosis in the control arm, well, if you consider this, you may extend this new paradigm not only to the refractory patients, where the threshold may be put higher. Why is that? Because there is a relationship between the absolute gain and the hazard ratios as a function of the median survival in control. For example, with a 6 months median survival, that's the kind of late stage advanced solid tumors, we may shoot at 0.7 of hazard ratio as an endpoint that will translate in only 2 months. That is 50% of what the Blueprint project is proposing. But that will already be somehow relevant, whereas 0.8 hazard ratio is definitely not relevant under condition of median survival in control of 6 months. However, see what happens when the median survival in the control arm is 24 months. Then even a hazard ratio of 0.8 would translate, again, assuming the linear, the proportional increase in the survival curves, even a 0.8 hazard ratio would not be to be disregarded, because that would mean 2 seasons gained, 6 months. So essentially, clinically worthwhile relative delta is a function of prognosis, and it is not a bad idea to use both hazard ratio and absolute gain. That must be considered. So now I go on to the last part and propose to you the work that we have done and trying to assign threshold values to these 4 parameters. And I have divided them into the small benefit for many, hazard ratio and median gains, and large benefit for few patients, and see what happens to the 50 trials. Actually, here, well, it could have become a problem in showing all these 30 pages tables. Okay, so I concentrated on the 31 indications on 21 drugs on 13 neoplasm and about 25,000 patients. Again, we have identified 4 prognostic categories, and we have spent a lot of time in setting the boundaries of these categories. And we ended up with this because it has some clinical relevance, identifying these 4 different categories, as well as having a fair number of trials within each category. Then we have tried a sort of intermediate between low level of expectation, intermediate, and high level of expectation. And what I'm showing to you is an intermediate level of expectation of raising the bar, okay? Where for the poor prognosis guys, we identify the threshold at the hazard ratio 0.65 and the gain at 2.5 months, and we raise up the threshold levels according to a better prognosis. Again, we have modeled this with various changes. And then here is what you end up with out of the 31 pivotal registration trials. That if you consider the threshold of 0.65, you have 1 trial only, and that's cetuximab versus best supportive care in colorectal cancer. 1 out of 8 trials would pass it. If we consider just the gain, 2.5, we have 4 trials passing this. And you can see the results there, and I will summarize saying that out of 31 trials, if you take those individual data, meaning using only hazard ratio or only the gain, you will end up with those trials passing the threshold. So if you go with either one, I may be satisfied with either one, okay, you end up with 20 trials passing the threshold out of 31. Whereas if you go for both, you have just 1/3 of trial making it. Now, if we consider a higher level, and by higher I mean a 0.05 different, lowering the hazard ratio further by 0.05, and raising the bar for the median gain by 0.5 months, then the figures become prohibitive. Only 6 trials would make it out of 31. Whereas if we lower the bar for all this, we may end up with a more reasonable condition, where 25 out of 31 would have made it. Finally, if we consider the other parameter, the large benefit for few, the situation is even more dramatic. First, because out of 31 trials, only 8 have data reliable. And out of 8 of these trials, none would have passed with both criteria of increasing the 2-year on 3-year proportional survival. So that's my conclusion slide. It is okay to raise the bar, but I think we have to be realistic, and we shouldn't shoot at miracles. We kind of should maintain the system to allow than the a posteriori identification of subgroups. And at the same time, for subgroups, we may shoot at miracles. And also, with age, I have become more respectful of regulatory bodies because I realized how tough their jobs is. Thanks very much.